Hello, my name is Dr. Mark Socinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. In non-small cell lung cancer, particularly the non-squamous population, comprehensive genomic testing is the standard of care. We now have 9 alterations, genomic alterations, in which the FDA has approved therapies for. All of these are oral TKIs. On that list is BRAF mutation positive non-small cell lung cancer. Again, this occurs in 1 to 2% of patients with advanced non-small cell lung cancer, preferably non-squamous non-small cell lung cancer. It can occur in smokers as well as non-smokers, and so there's really no reason to not test or include this in your comprehensive genomic testing. Now, we have a FDA-approved regimen, the combination of dabrafenib and trametinib, dabrafenib, the BRAF inhibitor, and trametinib, a MEK inhibitor. Interestingly, as the story unfolded, dabrafenib was first tested as a single agent in previously treated patients, had a response rate of about 35–40%. But the addition of trametinib, which is, again, the MEK inhibitor, this is a downstream signaling site distant to BRAF, that the response rates was vaulted into the 65% range. And that response rate of 65% was seen both in the previously treated patients as well as the treatment-naive patients. So a very nice option for patients in the first line or the second line setting. This is a population of patients that tends to have an improved overall survival. Median survivals in the range of 18 to 19 months or so. So this is a population that you definitely really want to identify to offer them this treatment, whether that be in the first line setting or the second line setting. One of the unusual toxicities of this combination is pyrexia, so be prepared for that. It can be managed effectively with antipyretics, and importantly, shouldn't be a reason for discontinuing the drug. Again, given the activity, this is a very good option for BRAF mutated populations with non-small cell lung cancer, and certainly my go-to regimen in the first line setting, given the response rate of about 65%. And some durability, usually in the 10 to 12 month range of those responses. Again, these patients would move on to other therapies for second line treatment, including platinum-based chemotherapy. And this is also a group of patients that probably because it's more commonly seen in smokers than some of the other genomic alterations we see. These patients of all the driver mutations, like the KRAS mutation positive populations, the BRAF mutation positive populations, tend to get a little bit more impact from immunologic approaches. So that would certainly be a consideration in the BRAF mutation population. But again, should be on your list of comprehensive genomic targets, assessed at the time of diagnosis. And if you do find a BRAF mutation positive non-small cell lung cancer, my standard treatment is the combination of dabrafenib with trametinib based on the data we have in previously untreated patients.